How do we approach the treatment of stroke? So primary prevention in the population group, reducing smoking, treating blood pressure, improving diet, and promoting exercise is obviously the principal strategy to prevent strokes. In those who have risk factors, and they are diabetes, high blood pressure, previous warnings or TIAs as we've discussed earlier, these groups of patients benefit from treatment strategies that are rather more accelerated than the normal population. For example, starting aspirin for treating blood pressure very well, and these have all been shown to reduce the risk of subsequent strokes. We all know about aspirin, and it's been in treatment vogue for many, many years, and that was the acute management for stroke up to 10, maybe 15 years ago. What's very exciting now is the acute treatment of stroke with interventions and with rehabilitation. And one mightn't think that rehabilitation is that exciting, but in fact it is. And it is probably the best proven treatment for any stroke patient. Secondary prevention I'll come on to in a minute. So, looking at rehabilitation, stroke unit patients versus non-stroke unit patients. The Cochrane report in 2001 looked at the number of people who returned home and the number of patients that you need to treat in order to get an extra person home between a stroke population treated in a stroke unit versus that treated on a normal, non-organised acute medical ward. I don't use the term non-organised with any disparity, but it is organised care, organised stroke specialist care versus ordinary hospital care. 5 more return home, 4 fewer died, and 3 less are institutionalised from 100 patients. And this is significant, and this is a real benefit to treatment. This is real patient impact.